Myself, Dr. Surendra Kumar, Assistant Professor, Department of Cardiology, UNMICRC, Institute of Cardiology and Research Center, Ahmedabad. I am presenting management of systemic hypertension beyond pharmacology. Hypertension management include pharmacological and non-pharmacological intervention for effective control of blood pressure. Despite availability of very effective medications, BP cannot be controlled in about 70% who receive only pharmacological interventions. Non-pharmacological intervention can be utilized alone before starting pharmacological therapy or in combination with. Non-pharmacological intervention help to reduce daily dose of antihypertensive medications and delay progression from pre-hypertension to hypertension stage. Non-pharmacologic therapy include lifestyle modification, renal artery stenting, renal denervation, baroreceptor activation. Lifestyle modification including dietary intervention for blood pressure control, obesity and body weight, physical activity, reduced physiological stress and anxiety, and cigarette smoking. DASH diet, dietary approach to stop hypertension. DASH diet was designed for the prevention and effective management of hypertension. The DASH dietary pattern is high in vegetable, fruits, low-fat dairy products, whole grains, poultry, fish and nuts, low in sweets, sugar-sweetened beverages and red meats, low in saturated fat, total fat and cholesterol, and rich in potassium, magnesium and calcium as well as in protein and fiber. DASH diet include a number of servings. Number of serving different for different calorie requirement. Like DASH diet chart for an average adult with moderate activity include 2000 kilocalorie per day as shown in chart. In an 8 weeks DASH trial, total 459 participants were randomly distributed in the following 3 groups: control diet group including calcium, magnesium, potassium as 25% of US diet, micronutrients and fibers, while in fruits and vegetable diet, fruits and vegetable increased to 8.5 servings and potassium and magnesium increased to 75%, while DASH combination diet add 2 to 3 serving low fat dairy to fruits and vegetable diet including also calcium, potassium and magnesium increased to 75%. The salt intake was kept constant in all these 3 groups. At the end of trial, in combination diet group, the reduction in both systolic blood pressure and diastolic blood pressure was 6.9 by 3.7 mm of mercury in black population as compared to 3.3 by 2.4 mm of mercury in white population. While in combination diet, lowered blood pressure more in hypertensive patient 11.4 by 5.5 mm of mercury as compared to normotensive person 3.5 by 2.1 mm of mercury. DASH trial as graph showing there is marked decrease as compared to control diet in fruits and vegetable diet and in combination diet more than above of both. Omni-Heart trial, optimal micronutrient intake to prevent heart disease trial. It included 164 adults who had systolic blood pressure reading of 120 to 159 mm of mercury and compared 3 diets each containing 2300 mg of sodium per day. 3 diets include DASH diet alone, DASH diet substituting 10% of total daily carbohydrate with protein, DASH diet substituting 10% of total daily carbohydrate with mono unsaturated fats, preferably from vegetable source. In this study, provided all foods and beverages to participants for 6 weeks. During the study, participants stayed the same weight. Trial result compared with the carbohydrate diet. The protein diet decreased systolic blood pressure by 1.5 millimeter of mercury in African American, while 1.4 millimeter of mercury in non-African Americans, while the unsaturated fat diet lowered systolic blood pressure 1.2 millimeter of mercury in African American, while 1.5 millimeter of mercury in non-African Americans. Another trial, OmniCarb trial, randomized crossover controlled feeding trial, 163 overweight adults with systolic blood pressure 120 to 159 millimeter of mercury were given 4 complete diets, each for 5 weeks, and completed at least 2 study diets, including high glycemic index 65% on glucose scale and high carbohydrate diet 58% energy, and second, low glycemic index 40% and high carbohydrate diet, high glycemic index, low carbohydrate diet 40% energy, a low glycemic index and low carbohydrate diet. Each diet was based on a healthful DASH diet. In this 5-week controlled feeding study, diet with low glycemic index of dietary carbohydrate compared with high glycemic index of dietary carbohydrate did not result in improvement in insulin sensitivity, lipid level, or systolic blood pressure. To determine the combined effect of DASH diet and exercise, at 16-week ENCORE trial was conducted on 144 overweight hypertensive individuals randomized in 3 groups, including DASH diet alone, DASH diet plus behavioral weight management, and usual diet control group. Blood pressure reduction of 16.1 and 9.9 millimeter of mercury was observed in DASH diet plus weight management group as compared to 11.2 by 7.5 millimeter of mercury reduction in DASH diet alone and 3.4 by 3.8 millimeter of mercury reduction in usual diet control group. Second is traditional Mediterranean diet. A study conducted in Mediterranean region in 1950 reported that people living in this region live longer and have less serious disease as compared to other European regions. Lifestyle and dietary habits of that population may be responsible for this, including Mediterranean diet. There is no uniform definition of Mediterranean diet in randomized control trial and cohort study examined. The main feature of Mediterranean diet are higher in fruits, particularly fresh fruits, vegetable, whole grains, fatty fish, rich in omega-3 fatty acids, lower in red meats, and emphasizing lean meats, fat-free or low-fat dairy products substituted for higher-fat dairy foods, and had oil like olive or canola, nuts, margarine. Strict implementation of Mediterranean diet resulted in reduction of systolic blood pressure by 3.1 millimeter of mercury and diastolic blood pressure by 1.9 millimeter of mercury. On the other hand, moderate compliance resulted in 2.4 millimeter of mercury reduction in systolic blood pressure and 1.3 millimeter of mercury reduction in diastolic blood pressure. While meta-analysis, a traditional Mediterranean diet associated with 2.35 millimeter of mercury reduction in systolic blood pressure and 1.58 millimeter of mercury reduction in diastolic blood pressure. PREDIMED study. This trial showed an overall reduction in CV outcome in the dietary intervention group driven by a decrease in stroke, as an endpoint closely associated with blood pressure. Meta-analysis shows small overall reduction in blood pressure associated with Mediterranean diet. Consumption of Mediterranean diet pattern correlated with improvement in numerous biomarkers associated with CV benefits, including anti-inflammatory effects as assessed by reduction in CRP level. However, the most recent AHA-ACC guideline on lifestyle management assessed the strength of evidence as low regarding the consumption of Mediterranean diet pattern versus low fat dietary pattern. Third is sodium restriction. Sodium play an important role in physiology of hypertension. A high salt diet leads to pro-fibrotic changes in vascular smooth muscle through introduction of collagen synthesis. This collagen deposition in blood vessel leads to arterial stiffness. Daily sodium intake of 2400 mg is considered normal or beneficial, whereas further reduction to 1500 mg in 24 hours recommended in person who are at increased risk of hypertension or stroke. Several clinical trials to evaluate the effect of high sodium on hypertension includes TOHP1 trial of hypertension prevention phase 1. The intervention group received counseling with aim to reduce sodium intake to 1400 mg in 24 hours, while the control group received no such intervention. After 18 months, 44 millimole per 24-hour reduction from baseline in urinary sodium was observed. This reduction in urinary sodium was more prominent in white women as compared to African American population. The larger systolic blood pressure reduction effect was observed in women than in men. 4.4 mm of mercury versus 1.2 mm of mercury with significant p-value. The net reduction in blood pressure in restricted sodium intake group was 2.1 mm of mercury in systolic blood pressure, 1.2 mm of mercury in diastolic blood pressure as compared to control group. It was further observed for every 100 millimole per 24-hour reduction in urinary sodium that there is a reduction of 1.4 by 0.9 mm of mercury in blood pressure. A 15-year follow-up study revealed that dietary sodium restriction decreases the risk of long-term cardiovascular event by 25%. DASH sodium trial. DASH sodium trial conducted in 412 participants with or without hypertension were randomly assigned to either control diet group, typical US diet, or DASH diet group. 3 diet group consumed high, intermediate and low sodium food for 30 consecutive days in random fashion. Above systolic blood pressure, the DASH diet was associated with significantly lower blood pressure at each sodium intake level, high, intermediate as well as low sodium intake. In comparison to controlled diet, high sodium intake, the DASH diet was low sodium content led to systolic blood pressure reduction of 11.5 mm of mercury in hypertensive individual, which is equal to the blood pressure lowering effect of single drug therapy. The 2013 AHA-ACC lifestyle management guidelines concluded that in adult age 25 to 80 year with systolic blood pressure 120 to 159 mm of mercury, reducing sodium intake lower blood pressure. The guideline further found the evidence as strong that for adult age 30 to 80 with or without hypertension, reduction of sodium intake by approximately 1 gram daily lowers systolic blood pressure by 3 to 4 millimeter of mercury. Potassium supplementation. Potassium intake has an inverse correlation with hypertension. Recent research showed that potassium consumption had an important role in salt-sensitive hypertension, especially in blacks. Salt loading increases blood pressure by 6.8 millimeter of mercury in African black versus 1.9 millimeter of mercury in white when given low potassium diet. This hypertensive effect was reduced by 4.9 by 3.3 millimeter of mercury in blacks versus 2.5 by 1.9 millimeter of mercury in whites. With high potassium diet 70 millimole per day. Intersalt trial, 287 participants revealed that participants receiving 96 millimole potassium supplementation per day resulted in more blood pressure reduction 1.9 by 0.6 millimeter of mercury as compared to placebo. Minimizing alcohol intake. Reduction of alcohol intake is one of the recommendation in JNC 8 guidelines. Excess alcohol consumption is responsible for 5 to 30% of all hypertension cases. Alcohol intake is directly correlated with elevated blood pressure. The reduction in weekly alcohol from 452 to 64 milliliter was found to be associated with 5 by 3 millimeter of mercury reduction in blood pressure in 3 weeks. A meta-analysis show alcohol reduction was associated with 3.3 by 2.04 millimeter of mercury reduction in blood pressure. A Japanese study in 539 participants revealed that increase in blood pressure directly related to alcohol consumption. As compared to non-drinker, mild drinker had blood pressure 2.1 by 1.7 millimeter of mercury higher, while moderated drinker had blood pressure 3.0 by 2.9 millimeter of mercury higher, and heavy drinker had blood pressure 2.3 by 2.0 millimeter of mercury higher as compared to non-drinker. NHANES 3 study conducted on women revealed that the average systolic blood pressure was higher in women who consumed 30 mg more alcohol than those who consumed moderate to less alcohol, and use of contraceptive increased the hypertensive effect of alcohol in women. Sugar sweetened beverages. The increased consumption of sugar sweetened beverages worldwide has been linked to the epidemic of obesity, particularly in young person. Evidence also support the association between increased consumption of sugar sweetened beverages and higher level of blood pressure. A prospective analysis of premier study showed that after adjustment for confounder, a reduction in sugar sweetened beverages by one serving daily resulted in an almost 2 millimeter of mercury decrease in systolic blood pressure. Obesity and body weight. Visceral adiposity and other ectopic fat deposits may also be associated with hypertension. As with other component of metabolic syndrome, hypertension may develop in Asian at a lowest waist circumference than in whites or blacks. Weight reduction might eliminate considerable morbidity associated with hypertension and lessen number and dosage of blood pressure drugs, and thus unwanted medication side effects. Risk of hypertension according to individual factor evaluated on the basis of estimated population attributable risk. Blood BMI more than 25 is associated with 50% risk as compared to 95% confidence interval. Non-narcotic analgesic use 70%, no DASH diet 14%, no vigorous exercise 14%, no or excessive alcohol 10%, and folic acid use less than 400 microgram per day, 4% attributed risk. Physical activity, major lifestyle modification. A meta-analysis of 54 randomized controlled trial involving 2,419 participants revealed that more than equal to 150 minutes exercise per week decreased blood pressure by 5.13 by 2.78 millimeter of mercury, while 121 to 149 minute per week exercise resulted in 4.67 by 2.11 millimeter of mercury reduction in blood pressure. Less than or equal to 120 minute per week exercise resulted in 2.82 by 2.19 millimeter of mercury reduction in blood pressure. This hypotensive effect was found equal in normal BMI and normal blood pressure group, as well as in high BMI and high blood pressure group. A meta-analysis of 28 randomized controlled trial involving 1012 individuals divided in 33 subgroups revealed that dynamic resistant training exercise resulted in reduction of both systolic blood pressure and diastolic blood pressure by 2.6 by 3.11 millimeter of mercury respectively, as compared to a non-training controlled group. Isometric hand grip training exercise resulted in 11.8 by 5.8 millimeter of mercury reduction in both systolic and diastolic blood pressure as compared to non-training control group. Combined effect of weight loss and sodium restriction. A randomized control trial of non-pharmacological intervention in the elderly TONE trial. It include combined effect of sodium restriction and weight loss on blood pressure. 975 participants with follow-up period of 15 to 36 months were divided into 4 subgroups. There is BP reduction by 3.4 by 1.9 millimeter of mercury in dietary sodium restriction alone group, while 4.0 by 1.1 millimeter of mercury in weight loss alone group, 5.3 by 3.4 millimeter of mercury reduction in combined sodium restriction and weight loss group, while in usual care group only 0.8 by 0.8 millimeter of mercury blood pressure reduction. Similarly, second phase of TOHP2 trial, 2,382 participants were also randomized in 4 subgroups after 6 months as compared to control group. There is 3.7 millimeter of mercury reduction in systolic blood pressure and 2.7 millimeter of reduction in diastolic blood pressure in weight loss group, while 2.9 millimeter of mercury reduction in systolic blood pressure and 1.6 millimeter of mercury reduction in diastolic blood pressure in low sodium group. Combination group show 4.0 millimeter of mercury reduction in systolic blood pressure and 2.8 millimeter of mercury reduction in diastolic blood pressure. However, after 36 months, blood pressure reduction were attenuated and remained statistically significant for systolic blood pressure and diastolic blood pressure in weight loss group and only for systolic blood pressure in low sodium group. Diet, exercise, weight intervention trial was conducted to simultaneously assess the efficacy of DASH diet, aerobic exercise and weight loss intervention for treatment of hypertension. Total 44 hypertensive obese individual with blood pressure of 130 to 170 systolic and 80 to 100 millimeter of mercury diastolic on single blood pressure medication were randomized into lifestyle and control group for 9 weeks. The lifestyle group was given a hypocaloric DASH diet that provided 100 millimole of sodium per day and 30 to 40 minute moderate intensity exercise 3 times a week. The control group received no intervention. At the end of trial, Mean weight loss in lifestyle group was 4.9 kg. Similarly, the net mean blood pressure reduction in lifestyle group was 9.5 mm of mercury systolic blood pressure with significant p-value and 5.3 mm of mercury in diastolic blood pressure with significant p-value as compared to control group. Corresponding changes in daytime systolic blood pressure and diastolic blood pressure were 12.1 and 6.6 mm of mercury respectively as compared to control group. Premier trial also assessed the effect of diet, exercise and weight loss simultaneously on hypertension. Total 810 stage 1 hypertensive patients who were not receiving any hypertensive medication were randomized into 3 groups: established behavioral interventional implementing established recommendation, established plus dash diet group, and advise only or control group. Net mean reduction in blood pressure was 3.7 by 1.7 mm of mercury in established group and 4.3 by 2.6 mm of mercury in established plus dash diet group. Reduced physiological stress and anxiety. Transient elevation in blood pressure occur in response to physiological stress and anxiety. The episode of stress and anxiety may lead to persistently elevated blood pressure. According to a research study, individuals who were lonely in either childhood or early adulthood had more chances to develop hypertension in later part of life. US Nurses Health study reported that victims of childhood abuse were associated with hypertension. Stressful events like sorrow, disappointment, disaster, and fear are positively associated with hypertension. Stress and anxiety lead to enhanced sympathetic activity through the release of epinephrine into blood, resulting in elevated blood pressure. Secondly, stress resulted in an increased cortisol release in body, leading to hypertension. Cigarette smoking. The effect of cigarette smoking on hypertension and outcome in hypertension patient remain difficult to define because of confounding by increase in waist girth with smoking cessation. Each cigarette evokes a transient pressure response that dissipate over the next hour. Despite the lack of precise mechanistic information regarding smoking and BP control, the overwhelming deleterious effect of smoking on CV risk as well as the public health benefit of preventing the start of smoking and promoting cessation of smoking. Various non-pharmacological intervention including all like physical activity, healthy diet, dash diet, weight loss, reduction in sodium intake, enhanced intake of potassium, moderation of alcohol intake. There is marked decrease in blood pressure in dash diet pattern including maximum of 11 mm of mercury in hypertensive group as compared to normotensive group only 3 mm of mercury. All these intervention there is decrease in blood pressure more in hypertension patient as compared to normotensive patient. Barrier to adoption and maintenance of lifestyle changes and possible solution. In practice, encouraging sustainable lifestyle change has proven extremely difficult. Individuals often express a low desire, interest, and awareness of dietary change, including weight loss, decreased sodium intake, smoking cessation, or reduced alcohol consumption. Barrier to adoption of physical activity recommendation include comorbid condition as well as limited time. Contemporary adjunct to the usual medical model for lifestyle intervention include internet-based interventions which are currently under intense evaluation. Another part of hypertension management include renal artery stenting in systemic hypertension. Atherosclerotic renal disease is a common condition with a rate of death of about 16% per year. Renal artery stenosis is associated with both hypertension and CKD. Treatment focused on correcting renal artery stenosis with endovascular revascularization, having gradually replaced open surgical techniques. 3 small randomized controlled trials showed no significant benefit of angioplasty over medical therapy. First trial is STAR trial, stent placement in patient with atherosclerotic renal artery stenosis and impaired renal function. Total 140 patient with EGFR less than 80, stable blood pressure less than 140 by 90 mm of mercury, and ostial renal artery stenosis of at least 50% stenosis. After 24 months, no significant difference in two groups, while primary outcome including 20% or greater reduction in creatinine clearance was observed. The trial has limitation with 25% of stenting arm that never actually received a stent. The STAR trial was criticized for its small cohort and exclusion of high-risk renal artery stenosis patient, including more than 70 to 80% luminal narrowing. Angioplasty and stenting for renal artery lesion, Astral trial, randomized unblinded trial, assigned 806 patient with atherosclerotic renal artery stenosis. After a mean follow-up of 34 months, there was no significant difference in kidney outcome, blood pressure control or CV events. Not only did 40% of enrollee have less than 70% stenosis, but 25% had normal EGFR, who would be considered very low risk status and likely not to have any benefit from stenting in the first place. The major criticism of Astral trial was allowing physician to only enroll patient if they felt that revascularization would be beneficial. Because of a lack of equipoise, there was a clear recruitment bias. Cardiovascular outcome in renal atherosclerotic lesion, CORAL trial, the largest renal artery stenosis trial, try and solve some of limitation and criticism of previous studies. A large cohort of 947 patient with systolic blood pressure more than 155 mm of mercury, more than 2 antihypertensive and EGFR less than 60. Primary composite outcome, death from CV or renal cause 4.4 versus 4.2 respectively for stent and medical group, while stroke 2.6 versus 3.4 respectively. Myocardial infarction 6.5% versus 5.7% respectively. Hospitalization for heart failure 5.9% versus 5.5% respectively. Progressive renal insufficiency 14.8% versus 16.3 respectively. Only significant finding in this trial was 2.3 mm of mercury lowering in stenting arm as compared to medical group. Various landmark trial in renal artery stenosis, starting with EMMA, with showing no difference in blood pressure in angioplasty group at 6 months, and also a recent trial like STAR, Astral and CORAL. ACC AHA renal artery stenting guideline, medical management recommended. If worsening in clinical status, then consider for revascularization. Renal denervation for hypertension therapy. Rationale of renal denervation in hypertension. Renal nerve contains sympathetic afferent and sensory afferent fiber and are recognized as important controller of kidney function and blood pressure. Sympathetic efferent fiber innervates the renal arteries, arterioles, renal secreting juxtaglomerular cells, veins and most tubular segments. Stimulation of renal sympathetic nerves can lead to increase in renal vascular resistance, tubular reabsorption of sodium, and renal renin release depending on stimulation frequency. Old studies of renal denervation in 1930, Page and Hoover reported that surgical bilateral renal denervation has no significant effect on blood pressure. Renal denervation decreased blood pressure for a few weeks. Clinical trials of renal denervation. The first catheter-based renal denervation radiofrequency method simplicity trial to bilaterally ablate renal nerves running along the main renal arteries. Enrolled 45 patients with systolic blood pressure more than 160 mm of mercury and on 3 or more antihypertensive drugs including diuretics. Reduction in office systolic blood pressure by diastolic blood pressure after renal denervation were impressive, 22 by 11 and 27 by 17 mm of mercury after 6 and 12 months respectively. Subsequent follow-up of these patients and additional subjects included in Simplicity Hypertension 1 indicated that blood pressure reduction persisted for up to 3 years. Simplicity Hypertension 2 trial, randomized control trial, 52 patients who received renal denervation and 51 patient control subject. This trial basically confirmed Simplicity Hypertension 1 demonstrating 32 by 12 mm of mercury reduction in office systolic blood pressure by diastolic blood pressure 6 months after catheter based renal denervation with no significant changes in control group. There were no significant changes in renal function as assessed by serum creatinine, EGFR, cystatin C, or no serious complication related to the procedure. Follow-up studies indicated that antihypertensive effect of catheter-based renal denervation persisted for at least 2 to 3 years. Enlightened 1 trial, a sham-controlled RCT which used a multi-electrode radiofrequency catheter-based system to ablate renal nerves, also demonstrated impressive reduction in blood pressure. However, an important criticism of these early trial is that they didn't include sham control group. Also, poor drug adherence is common in treatment of renal hypertension, but this was not monitored in some cases, making the studies susceptible to Hawthorne effect. That is, possibility that patient altered their behavior and medication adherence because of their awareness of being observed. Simplicity Hypertension 3 trial. The first randomized sham-controlled renal denervation trial was Simplicity Hypertension 3 trial, which failed to prove superiority of renal denervation compared with the sham control group. A total 533 patients were randomly assigned in a 2:1 ratio to undergo catheter-based renal denervation or sham procedure, and a constant regimen of 3 or more commonly recommended antihypertensive medication was mandated for both groups. The average decrease in systolic blood pressure at 6 months were 14.1 and 11.7 mm of mercury in renal denervation and sham group respectively, with no significant difference in 24-hour ambulatory systolic blood pressure. After 12 months, the reduction in office blood pressure were similar in renal denervation and sham group. A sub-analysis of Simplicity Hypertension 3 suggested that the failure of renal denervation to further reduce blood pressure compared with sham control subject was due to mainly large reduction in blood pressure in the sham subgroups of blacks, despite mandated regimen of constant antihypertensive medication. These limitations leads some to conclude that although the design of Simplicity Hypertension 3 had many strengths compared to earlier study, including a blinded sham control design and relatively large patient enrollment, execution of the trial was flawed and therefore it cannot be considered definitive. Denner hypertension trial, randomized controlled Denner hypertension radiofrequency based renal denervation added to a standardized stepped care antihypertensive. The average change in daytime ambulatory systolic blood pressure at 6 months was 15.8 by 9.9 mm of mercury in renal denervation group and the group receiving only standardized stepped care antihypertensive treatment alone respectively. Moreover, the number of antihypertensive and drug adherence at 6 months was similar in both groups. The major limitation of this trial are similar to previous trial that did not include sham renal denervation control or verify effectiveness of renal denervation. Spiral hypertension off med and spiral hypertension on med trial. Randomized double blind sham control study. Both used a new multi-electrode catheter designed to permit reliable circumferential 4-quadrant renal nerve ablation. Main renal artery and its branches. The primary results spiral hypertension off med trial in 80 patients including 38 renal denervation, 42 sham control. Renal denervation significantly reduced 24-hour ambulatory blood pressure from baseline to 3 months by 5.5 by 4.8 mm of mercury. In contrast to Simplicity Hypertension 3 trial in which participants received an average of more than 5 hypertensive agents, the effect of sham procedure was negligible with changes in ambulatory systolic blood pressure by diastolic blood pressure from baseline of only 0.5 by 0.4 mm of mercury. Spiral hypertension on med trial, stable doses for at least 6 months. Patient enrolled 467, underwent angiography and were randomized assigned to undergo renal denervation or sham control. Office and 24-hour ambulatory blood pressure decreased significantly from baseline to 6 months in renal denervation group but not in control. 24-hour systolic blood pressure by diastolic blood pressure average 7.02 by 4.2 mm of mercury reduction. Radiance hypertension solo trial, single blind randomized sham control trial used an endovascular high frequency ultrasound device to effect renal denervation in hypertensive patients who were off antihypertensive drugs. The trial showed that renal denervation caused small but significant reduction in 24-hour systolic blood pressure by diastolic blood pressure 7.0 by 4.3 mm of mercury reduction as compared to sham control. This fall in blood pressure was similar to antihypertensive response reported in spiral hypertension off med trial. Primary endpoints of recent clinical trial for catheter based renal denervation that included sham control. Spiral off med at 3 months show 5 mm of mercury reduction as compared to sham group in renal denervation group. In spiral on med trial, 6 month follow up show 7.4 mm of mercury reduction as compared to sham group. While radiance solo at 2 months there is 6.3 mm of mercury reduction as compared to sham group in daytime ambulatory blood pressure monitoring. Radio sound hypertension trial, a head-to-head comparison of radiofrequency and ultrasound endovascular renal denervation in 120 patients with renal hypertension who were randomized. Radiofrequency renal denervation of main renal arteries, radiofrequency renal denervation of main renal artery side branches and accessory arteries, endovascular ultrasound based renal denervation of main renal artery. After 3 months, ambulatory systolic blood pressure decreased by an average of 9.5 mm of mercury in whole cohort. Reduction was slightly greater in ultrasound ablation group than in radiofrequency ablation group of main renal artery, 13.2 mm of mercury versus 6.5 mm of mercury. Surgical renal denervation reduced renal norepinephrine content by 96% and completely normalized blood pressure in obese dogs with established hypertension. Radiofrequency catheter based renal denervation in obese dog with established hypertension, however, caused more modest decline in blood pressure associated with only 42% fall in renal norepinephrine level. Thus, in obese dog, the fall in blood pressure after renal denervation is almost directly proportional to effectiveness of sympathetic afferent nerve ablation as assessed by renal tissue non-epinephrine concentration several weeks after the procedure. Device therapy in management of systemic hypertension. There are significant number of patients who cannot be convinced to adhere to prescribed medication or whose blood pressure is not adequately controlled despite of adhering to medication. Many patients have high sympathetic activity may be controlled by non-pharmacological neuromodulation. Two device-based therapy suppressing the sympathetic activity are there, including electrical activation of carotid baroreflex and catheter-based renal nerve ablation. Both approaches are strongly supported by experimental studies and early clinical trials. Baroreceptor activation for hypertension therapy. Baroreceptor activation lower blood pressure chronically in experimental model of hypertension and in patient with resistant hypertension. In addition, sustained modulation of autonomic activity have blood pressure independent cardioprotective and nephroprotective effects. Clinical studies conducted in 1960, early 1970, stimulation of electrodes wrapped around carotid sinus nerve through crude to achieve reliable, sustainable baroreceptor activation and chronic antihypertensive responses, particularly in absence of adverse effects. Consequently, controlled clinical trials were not possible. Thus, this device-based approach for treatment of hypertension was abandoned by mid-1970. The first generation system developed by Rio system addressed several major limitations of earlier approaches. The Rio system for carotid baroreceptor activation achieved bilateral electrical field stimulation of carotid sinus wall with electrode placed around the carotid sinuses rather than stimulation of carotid sinus nerve. The second generation barostim Neo system is based on unilateral carotid sinus stimulation with a smaller disc shaped electrode sutured to the surface of carotid sinus. This is baroreceptor activation therapy. Carotid baroreceptor stimulation leads to stimulation in brain autonomic nervous system, inhibited sympathetic activity, enhanced parasympathetic activity, which leads to decreased heart rate, response on heart, and effect on vessel, increase vasodilatation, decrease stiffness of vessels, and effect on kidney, increase natriuresis, decrease renin secretion, thus lead to decreased hypertension. Clinical studies with RIO system debut HT European trial. Device-based therapy in hypertension trial, non-randomized, and endpoint of blood pressure reduction and safety at 3 months post-surgery in 45 patients with resistant hypertension, systolic blood pressure more than 160, diastolic blood pressure more than 90 mm of mercury. After 3 months of therapy, there was statistically significant reduction in systolic blood pressure 21 mm of mercury and heart rate 8 beats per minute. An extended follow-up phase, bradycardia persisted and reduction in systolic blood pressure exceeded 30 mm of mercury after 1 and 2 years of therapy. At each visit, device was temporarily turned off to assess the blood pressure without activation. At that time, blood pressure increased rapidly toward baseline level, confirmed sustained antihypertensive effect and rapid off transient response to deactivation. RIO pivotal trial, randomized controlled double-blind trial with endpoints of safety and blood pressure reduction at 1 year in subjects with resistant hypertension. Subjects were implanted RIO system bilateral implants. Majority of these programmed for unilateral. 265 patients were randomized 2:1 1 month after surgery. Baroreceptor activation, the first 6 months immediate baroreceptor activation and baroreceptor activation delayed for first 6 months of trial, delayed baroreceptor activation. Five co-primary endpoints were established. First is acute systolic blood pressure responder at 6 months, sustained responder rate at 12 months, procedure safety, baroreceptor activation safety, device safety. Immediate baroreceptor activation group, systolic blood pressure reduction by 16 mm of mercury at 6 months and 27 mm of mercury at 12 months when compared with the 1 month post-implant value before activation. Delayed baroreceptor activation group, reduction in systolic blood pressure 9 and 25 mm of mercury at 6 and 12 months respectively. To optimize battery longevity, unilateral stimulation was chosen in 75%. Acute fall in blood pressure was not greater with bilateral. RIO HT study, unilateral carotid sinus stimulation, sustained reduction in blood pressure in patient with renal resistant hypertension was observed. There is differential and common effect of baroreceptor activation and renal derivation in obesity hypertension. Mean arterial pressure, heart rate, baroreceptor sensitivity and pulse interval. As shown with developing obesity, there was rise in mean arterial pressure and heart rate, while decrease in baroreceptor sensitivity and pulse interval short-term variability. While as we do baroreceptor activation, there is decline in mean arterial pressure and heart rate, while increase in baroreceptor sensitivity and increase in pulse interval short-term variability. This was more in baroreceptor activation and also observed in renal denervation. Barostim Neo trial, single arm open label study, evaluated efficacy and safety of second generation system for baroreceptor activation in 30 patients with resistant hypertension. Implant unilateral suturing of miniature electrode onto surface of carotid sinus. After 3 months of baroreceptor activation, systolic blood pressure was reduced 26 mm of mercury. After 6 months, this fall in blood pressure persisted along with reduction in a heart rate of 5 beats per minute. After 6 months, 43% subject achieved systolic blood pressure less than equal to 140 mm of mercury. Compared with Rio HT trial, procedural complication decreased from 25 to 3%. Of particular interest, 6 of 30 patients enrolled in Barostim Neo trial underwent previous renal denervation, which was unsuccessful in lowering blood pressure. After 6 months of baroreceptor activation, reduction in systolic blood pressure and heart rate were comparable in these patients when compared to the subject with intact renal innervation. Despite impressive result of Barostim Neo trial, second generation device for resistant hypertension in US will depend on outcome of randomized controlled Barostim Neo hypertension pivotal trial. Randomized controlled trial have been completed but are ongoing in France and in Nordic countries. Barostim Neo hypertension pivotal trial is currently suspended as company resources will only allow adequate oversight for one pivotal trial at a time. Advantages: chronically suppress sympathetic activity and blood pressure without significant long-term counteracting increase in renin secretion or sodium retention. Had rapid on and off BP responses. Because device can be turned off transient allow identification of true responder during routine follow-up visit. Increase cardiac baroreceptor sensitivity and heart rate variability. Maintain or improve sympathetic baroreflex sensitivity. Chronically increases cardiac parasympathetic activity and decreases heart rate. Attenuates autonomic imbalance when dysfunction is present. May chronically increase ANP secretion through changes in cardiac autonomic activity. Chronically suppress renin secretion. Chronically lower blood pressure even in absence of increased baseline sympathetic activity. Chronically lowers blood pressure even after renal denervation. Adds to the blood pressure lowering effect of antihypertensive drugs commonly used for resistant hypertension therapy. Diminishes glomerular hypertension and hyperfiltration in obesity, which are precursor of progressive renal injury, along with lowering blood pressure, reduces GFR modestly and non-progressively when baseline level of GFR are normal or reduced. Limitation: implants require a minimally invasive surgical procedure. Pulse generator replacement needed every few years. Minor side effects are not uncommon. Efficacy and safety of Barostim Neo system have not been confirmed in randomized controlled trials. Take home message: proper management of hypertension require both pharmacological and non-pharmacological intervention. Both interventions have additive effect. According to American Society of Hypertension guideline, 6 to 12 month lifestyle modification can be attempted in stage 1 hypertension patient without any cardiovascular disease, in the hope that they may be sufficiently effective to make it unnecessary to use medicine. Non-pharmacological intervention for hypertension mostly include lifestyle modification. Renal artery stenting and renal denervation in management of systemic hypertension in different clinical trials shows contradictory evidences and need for further randomized trial in future. Device therapy baroreceptor activation in management of systemic hypertension future is more promising. Thank you.